Hi, and welcome to today's video and podcast, the Spinal Decompression Show. My name is Steve Small, and I'm delighted to be joined by Professor Amjad Shad, consultant neurosurgeon and spinal surgeon. We've known each other for a little bit, and absolutely delighted to have you on today. How are you doing, Amjad?
Thank you very much, Steve, for getting me on board. I'm doing very well.
Excellent, excellent. So perhaps you could just sort of start off with just, as a professor, neurosurgery and spinal surgery, just tell us a little bit about yourself, Amjad, if you would, and where you work and what your
I was
background is.
trained in Edinburgh.
Okay.
I did my neurosurgery training in Edinburgh, and then from Edinburgh, I moved to Oxford, where I did 3-year fellowship in the spinal surgery. And then I completed my neurosurgery training in Oxford. And then in between, I did another spinal fellowship in Liverpool. And I also traveled to USA to have further exposure for the spinal surgery. And my main interest is in degenerative spinal conditions, back pain, neck pain, and I also do skull-based surgery.
Okay. Where are you working at the moment?
At the moment, I'm working at University Hospital Coventry.
Okay.
In Warwickshire.
In the Midlands. Okay. Excellent. And you have some connections working with Pakistan as well?
I do. I am involved in training courses and workshops in Pakistan. I'm also involved in the exam in neurosurgery in Pakistan.
Excellent. Okay, well, thanks for the intro. So a lot of people, coming to see you, and generally, with these sort of back pain, neck pain, and conditions. As a neurosurgeon, when would patients typically come and seek you out?
The most common cause of the back pain is mainly the musculoskeletal causes due to the poor posture, lack of exercise, poor back muscle health, and sometimes in the limb asymmetry, and these are the common causes. And most of these patients are treated by the physiotherapist, chiropractor, and osteopath, and pain management team. And by improving their posture and health of the back muscle, most of these people, the pain becomes manageable. The patients we get is mostly the patients who have failed the conservative treatment, and patients who have a pain either radiating down to the arm or leg, suggestive of radiculopathy, weakness, or Cauda-Equina syndrome. But we still keep getting patients both with the back pain and the neck pain also without radiculopathy.
Okay. Would you say so? Is leg pain the biggest problem that people come to see a neurosurgeon for, or is it a mix? Or
I think it's part of my practice, but back pain is the second common cause of the consultation to the clinicians after the flu.
Yeah. Okay.
So yes, we get a lot of people with the back and neck.
And of the patients that come to see you, and obviously you're seeing a variety of conditions, and perhaps it does depend from surgeon to surgeon and the process before someone comes to see you. But of the patients that you see who perhaps haven't responded to those treatments, what sort of percentage would you say actually go on to have a surgical intervention?
So typically the patient with the lumbar disc prolapse, 80 to 90% of the time disc heals without surgical intervention. We know that. And then basically you have to support them during that time with the pain, and you actually bind time for nature to heal the disc. And we educate the patient how to facilitate nature to heal it. And then we also advise them appropriate therapies during that time to help them with the pain and facilitate the nature to heal the disc. So in my experience, only around 10% people end up having surgery.
Okay.
The rest successfully can be treated with improvement of their posture, improvement of the health of their back muscles, and the other treatments.
And is that 10%? Is that would you say that's fairly common across your colleagues?
I think it varies. It varies from person to person. But I think majority, only end up operating is 10 to 20%.
Okay. And I know you also do, a variety of sort of spinal injections. I mean, are they, what's the most common spinals, the injections that you give, and again, what sort of percentage of patients might benefit from an injection?
So I think the injection is essentially when you have a prolapsed disc and it inflames the nerves, So that you get pain for two reasons down the leg. Is one is the pressure on the nerve, and the second reason is the inflammation of the nerve. The injection, which is cortisone injection, a steroid injection, which basically helps to take the inflammation away, and that way it helps to reduce the leg pain. And while the injection is working, the disc is healed by the nature, and by appropriate posture adjustments and by the exercises and improving the health of back muscle. Typically, we advise patients to avoid prolonged sitting, prolonged standing, bending and lifting at the same time, bending and twisting at the same time, and heavy lifting and shifting.
Okay.
And that's the way you're actually giving nature a chance to heal the disc.
Right. Okay. Excellent. Come on, just to circling back to those patients who you do, you do operate on, and where the decision is to operate. What is the key thing? When would you operate? I mean, I sometimes tell people, my late father, he had the IDD spinal decompression for his lumbar spine, and he had a surgical intervention for his neck. He lost balance. What would be your message of, when particularly are you looking at a patient from a surgical perspective and potentially going to do an operation?
The group which we end up operating on is one with the intractable leg pain. In spite of doing all the conservative measures, pain is not improving and is significantly interfering with life and is significantly limiting their physical abilities. And pain is so bad that they can't function day-to-day basis. Then we do the surgery, but that's a small indication. The other group which surgery we offer is somebody with a limb weakness or cardiac corner syndrome, which is obviously an emergency.
Yeah.
So intractable leg pain, limb weakness with neurology, and cardiac corner syndrome. And
for people who don't know, what is cardiac corner syndrome?
The cardiac corner syndrome is when you have a large central collapse disc and it starts compressing the nerves which supply bladder and bowel, but then you are at risk of losing your bladder or bowel function. And that's why
that's an emergency.
Indication to operate on that.
Okay.
And the back pain and bilateral leg pain and bladder bowel disturbance.
Okay. And so if somebody's not got to, in terms of those criteria, and as you said, there's 10% of the patients that you see, presumably then if they've not got those form the 90% of patients that you wouldn't operate on, or that you might give an injection. Would that be right?
That's correct. I think then we resort for the alternative treatments, and as I said, the most important thing is to improve their posture.
Yeah.
Improve the health of their back muscles. Then we help them with injections. And the patient who have a small disc prolapse, we also give the indirect decompression with the help of IDD. And in my experience, about 60 to 70% people do get help with combination of IDD, physiotherapy, acupuncture, and the ultrasonic therapy to the muscles.
Yeah. So this category of the IDD spinal decompression, this is the treatment which sort of addressed the shortcomings and failings, I suppose, of traditional traction to sort of decompress and mobilize the targeted spinal segments. I know, like you say, you refer patients for IDD when manual therapy and exercise are not working. So you say that's primarily for the disc patients. Are they patients with disc bulges, or what about with degeneration?
The only treatment short of surgery which can achieve indirect decompression without needing the surgery. And the two groups which can benefit from it, patient with a small disc, where we hope that it's can heal with the time, and by giving the targeted IDD therapy, that is the traction to the level where the problem is, as compared to the previous traction treatment, an inversion table, where you were stretching the whole back and you can end up damaging the normal levels also. And the results were there was inconsistency in the results. So with this one, if with the appropriate amount of traction, you can slightly dislodge the disc away from the nerve, it helps with the pain. But ultimately, disc is healed by the nature. By doing this treatment, you're giving them an indirect decompression, which helps their pain, and they can wait for nature to heal it. And the other group which can benefit is patients who have a facet joint arthrosis and mild to moderate lateral recess stenosis, and there is compression of the nerve in the lateral recess, again, by giving the targeted decompression therapy, can help to decompress and help the patient with the lateral recess narrowing. And this is a separate condition from the acute prolapsed disc. The wear and tear and degeneration can lead to the narrowing. It could be central or lateral, central canal stenosis and lateral canal stenosis. And lumbar canal stenosis is a waxing and waning condition. A lot of people do get better with the conservative treatment. That's why I prefer to start with the conservative treatment, even people with the lumbar canal stenosis and lateral recess stenosis. And again, conservative treatment can help 50 to 60% of the patient. So rather than operating on everybody, we resort on these techniques before rushing for surgery.
It's interesting that when you were describing that, you know, we talk of decompression. You use the term decompression, but we also, we sometimes interchange that with this idea of targeted traction, which is focused at the level. I think we kind of get a little bit, you know, we tend to think of the old traction as that, you know, non-specific, whereas this sort of decompression or the targeted traction is focused to the level. I think there's another, you know, there is another component to it. It's not just the actual decompression of the disc, but that the working of the soft tissues, like you said. I think you know, with the body healing itself, if we improve the function of the tissues at the same time, get some more mobility, then the body has a better chance to you know, to heal it.
Well, I think you're absolutely right. We need to understand the cycle. If you have a weak muscles, that further increases the spondylosis. So with the decompression, we can also give the ultrasonic therapy to the patient to improve the vascularity of the muscles, and that further strengthens the muscles and they resist the load, because once the discs start wearing off, they offload to the back muscles, and that leads to facet hypertrophy, and that further leads to canal stenosis. So I think with this therapy, we can break that cycle by improving the health of their muscles and by doing the indirect decompression.
Yeah. Excellent. I like, yeah, the combination of things. So for you, exercise is a key part of the you know, the rehab and the recovery process for your patients, presumably whether they've had surgery or not. And especially if they have surgery, then yeah, for the long-term recovery. Do you see a different in outcomes where post surgery if people stick to an exercise program? Or
absolutely, I think people who are sedentary and have a poor muscle health, they take longer to recover, and they're prone to further adjacent level problems. People who are fit and they do regular exercises, they recover quicker and they have a less chance of further surgery. But in the long-term review, people who we do operate for the leg pain, at the end of 4 years, there's no difference between the surgical and non-surgical group. At the end of 10 years, the surgical group, there is 30% higher risk of further surgery as compared with if you treat them conservatively. So that's why I always prefer first to treat them with all the conservative tools I have in hand.
That's quite, I mean, that's quite significant.
Including physiotherapy and traction and injections if appropriate.
You know, in your sort of field and with your colleagues, what sort of trends have you seen and are you seeing within sort of neurosurgery and spinal surgery? Are you seeing any particular things happening at the moment?
I think the only thing which has changed is how you operate on these patients over the years. From open surgery, we moved to more into minimally invasive surgery and then endoscopic surgery. The whole idea is to do less damage to the muscle. As I said, this cycle of spondylosis, the muscle health is very important. If you damage the muscle or if you have a poor health of muscle, it further escalates the wear and tear. So the whole aim of all these new technology is to do less damage to the muscle. So the patient recovers quicker and the muscle get their tone back quicker. With the open surgery, with a lot of retraction, you end up doing more damage to the muscle, which can further cause trouble to the other levels.
Is there I mean, this is a sort of hypothetical question, you know, is there a case for, in terms of, you know, you're interested in the exercise, is there a case for potentially combining IDD, you know, with spinal decompression either pre or post the surgery to help improve the function, would you say, or?
I think yes, it increases the patient's mobility quicker, and it helps the patient to move around and helps with the stiffness. So I think post-operative rehabilitation period is also important with the physiotherapy and the muscle therapies.
Mm. So you got your professorship. Which year did you get your
I
professorship?
did it in 2014.
2014. Okay.
Yeah.
And what well, how did that come about?
This is all about the research I was doing on combining the brain with the computers.
Ah, okay.
So we did in Oxford, the world's first procedure of combining the brain with the nervous system with the computers.
Okay.
And then we continued that research. And the second part of my research was on the degenerative lumbar disc disease and the long-term outcomes and various factors affecting the escalation of the spondylosis.
Mm. Impressive, impressive, and clearly, I know from your work with some of the clinics that we know, they appreciate the input that you give with patients with difficult conditions, and sometimes patients, surgery is absolutely the right thing, and it's good to have people like yourself available to help. Okay. Well, thank you for going through those, those elements. I think it's really interesting for people to understand that there's a time and a place for surgery, and to hear from a surgeon that, you love what you do, you help people immeasurably. But sometimes if they can stay on the conservative side, then that's a desirable thing also. Is that a pretty fair summary,
Yeah,
would
I
you
think
say?
it's fair. I think my main message is, as far as pure back pain is concerned, people who come with the back pain, not with the radicular symptoms, there is very limited role of surgery for the back pain.
Right.
And there's no operation for back pain which works 100% time, and there's no operation for back pain without risks. So that is very, very select group which benefits from the surgery. And so first thing we need to establish is the source of the back pain is from the back. So there are a lot of musculators of back pain also, we exclude that. Then we exclude as patient got into a problem is with the posture. Sometimes high BMI can cause the problem. We optimize their weight management. Then we optimize their muscle health. And then indirect decompression, physiotherapy, ultrasonic therapy. I think all these are valuable tools to help with the pain. But surgery as such has a very limited role.
Excellent. And are you traveling at all? Have you got any conferences coming up, or are you going to
I'm traveling
Pakistan?
to Pakistan again in 2 weeks. We are running a workshop there.
Okay.
On the spine course we are running for the juniors.
And I think, it's great to hear that the IDD is now in Islamabad as well, with the clinic there. So, which is
I just heard that. I think the first clinic for IDD has opened in Islamabad.
Yeah.
And good luck to them.
Yeah, no, that's excellent. Okay, Amjad. Well, thank you very much for joining me today. Good luck with the trips, and really appreciate your insights today.
Thank you very much. Thanks.